Welcome back. We are here today to talk about a very hot topic, peptides, and hopefully we'll also talk about hormones. I'm here with Terry DeNeui, who is an expert in this area. She is the founder and owner of Avixis, and she was referred to me by my good friend Lynn Finn, who knows her well, who's credible source, because this is sort of a muddy area in medicine. I actually know about peptides more from my kids because they're on TikTok and
Yeah.
they're hounding me, Mom. I want to start taking these peptides, and they're consumed with, I need these peptides to be stronger and smarter. And I have one kid who's going through puberty and thinks that, the peptides, if he doesn't take these peptides, he's going to be short and all these things. So it is my pleasure to bring Terry DeNeui on. Welcome, Terry. And can you let's just get down to the definition of a peptide. I mean, why is it called a peptide? Why is it different from any other medication on the market?
Well, peptides are these tiny molecules that we make in our body, actually. They have multiple uses, multiple functions. I think probably the primary one most people know is insulin. Insulin is a peptide, right? That's made in our body. And peptides have been on market and been researched for a really, really long time. They've made a resurgence really heavily over probably the last decade, especially the last 5 years. I know everyone listening has heard of the GLP-1s. Those are a peptide. So peptides are again, a molecule that have different functions in the body depending on what receptors they're targeting. And so, but you said so much, and I'm excited to dig into the conversation around. I call it doctor talk. That has no medical degree or clinical background, but it makes me kind of nervous that so many people are getting advice from unreliable sources. And so I really appreciate you having this conversation.
Yeah. So I know that the FDA has been, I think maybe even last week, talking about how they're going to start regulating peptides. And I just went on one of the websites that my son had sent me about a year ago, and that's been shut down.
Yeah.
So what has been going on recently in terms of regulation of peptides and how people can access them?
So in 2022, out of the blue, the FDA decided to take 13 peptides off of, it could be more, that number could be higher, off of the safe to compound list and move them to the unsafe to compound list, for lack of better explanation. And overnight, literally, clinicians and patients were cut off from vitally important peptides. Now, I think that one of the things the kids are learning on TikTok is they're probably learning about the growth hormone secreting, stimulating peptides, but there's a myriad of other peptides for autoimmune dysfunction, brain function, reproductive function. There's just so many, inflammation. There's many, many peptides. And clinicians like myself that have been using them in office very successfully were just kind of taken aback. Literally overnight, patients didn't have access to them. What happened when that happened is it drove people to the underground market, and it drove certain, I would say, pharmacies that might have more on their mind than the health and well-being of people to illegally compound these peptides. And they found ways around them. And one of the ways that they found, which is still illegal, but they were able to do it for another couple of years, is labeling these peptides as research-only peptides. And so companies like the one that your son probably was on, I know, very familiar with that company, literally shut down overnight in the past couple of weeks because the FDA is now going after what we call gray market pharmacies that are producing and selling peptides across state lines. Now, there's a little bit of a gray area with peptides regarding if you have multi-state licenses. Some states didn't acknowledge the FDA stance on peptides. And if you were a pharmacy that only made peptides in that state and didn't cross state lines, which becomes interstate commerce, and now the FDA rules apply, then it was a little bit different. But companies like that company that got shut down, they were shipping peptides across the country. So they did fall under the FDA guidance. Our pharmacy that we own and use also has multi-state licenses, so we immediately stopped making them. But states like Texas and Florida and a couple of other states that don't recognize those rules, local pharmacies continue to make them. And it's a gray area. There's some interpretation of the law that, probably is okay. And they're reputable pharmacies that kept making them. But most pharmacies said, we're too afraid because you don't want to visit by the FDA, right?
Right.
And so it began this fight, or this argument that the FDA didn't follow their own process called PCAC to investigate whether a medication was truly safe and efficacious. So we were very involved in the PCAC, I don't want to say trials, but PCAC meetings in 2024. We actually instigated a lawsuit against the FDA because they illegally took them off of that list and they didn't follow their own process. That has resolved, and the administration, HHS, and the FDA has recognized that they didn't follow the right process. So now they are bringing those back on a safe to compound list and going through the correct process. And in that process, one of the things they are really heavily going after is the gray market, and making sure that compounders that are making them are green listed. They're getting their raw product from FDA inspected facilities. The problem is with a lot of these underground gray market is you don't know where they're getting their API from. You don't know if they're testing it for potency, purity, safety. So it's a really risky thing to just order something you're going to inject in your body from a pharmacy that's choosing not to follow the law.
Right.
That was the answer to your question, but
well, it is kind of odd that there's a subsection of a medication that you can inject in your body and the FDA doesn't really monitor it. I mean, our peptides, and I'm not talking about Ozempic and Wegovy. I'm talking about, why don't you tell, what are the hot peptides that all the teenage boys are into that will build muscle and make you stronger and that sort of thing? And are they still available?
I'd have to look and see what they're talking about, but my guess is they're talking about peptides like CJC, ipamorelin, or tesamorelin. And these are actually, they're not growth hormone peptides, which are illegal in most states, unless you are prescribed by an endocrinologist that's documented a growth hormone deficiency, but it is abused a lot. And there's a lot of these peptides like growth hormone and like some of the synthetic anabolic steroids that are kind of sold on websites for animal use only. And, it's very popular in the gym world and things like that, which is crazily unsafe. But what they might be talking about are these growth hormone stimulating peptides. So there's growth hormone releasing peptides and growth hormone stimulating peptides. And that's really what's very popular in the aging community. So people that are, losing that growth pulse, which starts at about 40 years old. Young people do not have this problem, and if you're growing normally and you're meeting milestones normally, there's absolutely zero reason for a young person, a teenager, to dabble in this space. And in fact, what it can do is cause the exact opposite, because when you start introducing these molecules in a normally functioning pubescent teenager that is still growing and still having hormone changes, you can really disrupt the system and cause the exact opposite. It can stunt your growth. It can cause pituitary issues. It can cause increased prolactin levels, which can cause breast tissue development in males. So I don't think any of these young males want breasts, right?
Right.
So these are all, and of course they've never been studied and researched in that population, which is a huge risk as well.
And so, where do things stand now? Can you still access these alternative peptides that are not owned by the drug companies,
Oh
or
yeah.
is it okay? But
Yeah.
you just have to go to a special local pharmacy. Is that you can't
So
order them off a website anymore?
you should not or
No.
ever have ordered them off a website. Let's start there. They should be prescribed under the close supervision of a trained clinician, period, full stop. And that trained clinician hopefully has the ethics to order from a licensed FDA inspected facility that is inspecting, and they are using good manufacturing processes. So right now, currently, most of these peptides are only available as a compounded medication. Compounded medications have been obviously around. They were the first pharmacies, right? I mean, the owner of Pfizer, the original founder of Pfizer, was a compounding pharmacist. And so that is where drugs began. And compounding is a very beneficial for patients and clinicians, because if there's not an available medication that a patient needs on market that's gone through FDA approval process and all of that, it gives a really great option for these patients to address issues. And I've got many stories of autoimmune patients that certain peptides have completely reversed their autoimmune issues. So some of the ones that are hot right now, to go back to that question, that we're really excited that they're coming back, are the CJC ipamorelin, which is amazing for age-related muscle loss, right? So sarcopenia, things like that. So this is age-related. It does have a big influence on sleep and inflammation. And these are all things that as we age, we're dealing with. Another really great one is thymosin alpha-1, which is a thymosin alpha-1 is secreted by the thymus gland up until the time that atrophies after puberty. And it's really powerful for immune response. The autoimmune clinics that had been using this, including myself in my own clinic, it was a really devastating blow to lose that. And unfortunately, I know several of my patients that decided to go to an underground pharmacy to get it because they had such great results that were afraid to go backwards and have immune flares that they were having. BPC 157 is a natural peptide made in our gut. That's another powerful injectable for inflammation. Again, with all of the gut disruption from our food and stress, BPC made in our gut is very compromised. So, that's a really big one that we're very excited to come back. And I just want to say, and we can talk about this if you want, but there are some areas and some room for certain peptides in younger people as it relates to injuries. There's great stories around certain peptides being injected in a local injury. One of my mentor in the peptide space, Dr. Jim Laval, he has a phenomenal story of a kid who had a Liz Frank injury in high school playing football. And technically this kid should have been out for a year healing. And they utilized some peptide protocols for inflammation and tissue repair that got him back on the field within about 3 months, which is unheard of with Liz Frank. So there are some supervised benefits. We have seen really sick kids that are dealing with specific issues, that peptides have been used very successfully under the guidance of a highly trained clinician. There are medical doctors across the country that are using them very successfully. That's a different story than a healthy kid like you're talking about.
Well, yeah, one of my kids, and I have 4 boys, and the oldest is really into powerlifting. And so he was wanting to inject it where, his muscles were really ripped up, or he said, But what I was going to ask with the autoimmune. So are these things that you could take in lieu of traditional autoimmune medications? Are they that powerful, or is it sort of a supplement to traditional autoimmune medications?
Yeah, most of the autoimmune medications are suppressing the immune system. These peptides are actually enhancing and your immune system, increasing natural killer T cells, decreasing NF kappa B, all this immune cascade. So it works in a very different way. And the patients that I've seen that use those successfully and that even have come to me in my clinic that I've used it have failed traditional therapies, or they have researched methotrexate and some of these other medications are just like, I don't want to go on that. I'd rather try another route first and let that be a last resort. And those are the ones that we've had great success with. So I'm not saying that you should do one over the other, but it is just an option, an alternative for people that might want to go that route. And it's very well studied. There are many published papers on thymosin alpha 1 and autoimmune. It's pretty amazing.
And do you have to inject it daily, or what's the typical routine?
Those are injected daily. The other thing that these kids don't understand about these other, peptides that they hear about in the gym is they're not being taught how to inject them. You have to cycle. Even if you were an adult, you don't take it every day forever and ever. There are certain protocols that you have to follow for safety that nobody's teaching them. They're just getting them and injecting them. Because when you order something from an underground pharmacy that's for research only, they're not sending you instructions.
Mm-hmm.
The assumption is you're working with a doctor who is telling you to buy this, so the doctor is researching the benefits, right? That's not how it's used, but that's the loophole that these pharmacies are operating under, and they know it's illegal. That's why the one big one shut down.
Right. And you mentioned sleep. You said there was a peptide that helps. Is that with insomnia? It helps with that?
Yeah. So CJC apomorelin, the growth hormone secreting peptide, and growth hormone releasing peptide. So it's two types of stimulating growth pulses. When one of the things that growth hormone is beneficial for is sleep. So when these peptides are given at night, because they're typically given at night, it does have a sleep side effect that signals the brain it's time to rest. And that's when repair and recovery is happening. These peptides last on average about 10 minutes in the system. So it's not like they're lasting 24 hours. It's enough to stimulate growth pulses when natural growth pulses could be stimulated. Now, I could go down a whole rant about what these kids can do to increase their own growth hormone naturally. The problem is they don't want to turn off their phones at night and decrease light stimulation and eat properly and have rest days in the gym and, all the things that are beneficial to, repair and recovery.
Have you seen any adverse reactions from the peptides?
I have not seen any adverse reactions from peptides. I've been using them for about almost 10 years, some of them, but definitely 8 years on most of them. Been co-leading and co-teaching with Dr. Jim Laval at peptide trainings. And we have just not seen any adverse. And that was one of the things that we were really imploring and taking studies to PCAC and presenting in front of the FDA, the safety, the anecdotal real world data around safety. So this has given us a real great opportunity. And we've actually, a colleague of mine has published quite many studies on, especially CJC and thymosin alpha 1 that have been just to educate the community specifically. But if you do see a reaction, it could be a local reaction, a local response. I have seen in patients that are very inflamed and very sick, when they initially start some of these peptides like CJC, they can have a Herxheimer's reaction. So their body goes into this big detox response, and you have all these inflammatory cytokines released from all the inflammation that is being addressed. And that can be kind of scary because it can cause this weird, flushing sensation. And in those patients, it's not life-threatening. You have to stop and you have to address what's going on, address the gut, address other things that are causing inflammation. Just like anything, people have to understand you have to tend to the soil. You have to give your body what it needs from food, from rest, before you, and start healing from the inside out before you start some of these things. And, another reason why just under a clinician that's trained, licensed to do this is just vitally important.
And you have a book, Hormone Havoc. Does it talk about peptides or do you focus mostly on hormones?
No, I don't. I don't focus on peptides at all in that book. The best book on peptides is Dr. Jim Laval's peptide book. He just released a second edition, and it is just the best primer on all the compounded peptides, and it's just phenomenal information. Many of the peptides that he talks about in that book are still not available in this country, but they are available in other countries. Cerebrolysine is a phenomenal brain peptide that we just saw such amazing benefits for Alzheimer's and neurovascular diseases. That was taken off market in like 2022. It was devastating for so many patients that were having a lot of great results with that. But I think that I don't think I know for a fact, there are some of these peptides that are being researched right now with pharma companies and will be coming on market for sure, which is great news. The bad news on that is they'll probably be priced so far out of anybody's affordability. That makes it challenging, which is another benefit of compounds because they are more affordable. But the good news is they'll be researched and studied, and that'll be really helpful for the industry.
What are your thoughts on GLP-1s? Do you
Again,
use them?
another, go ahead. Were you
Well,
going to
no, well, I mean, just is that something that you use in your armamentarium or what
We
what are your
do.
thoughts?
Yeah, I've been watching GLP-1s for a while, and I work with an incredible endocrinologist that actually did a lot of the preliminary research on GLP-1s before they came out. It was part of her residency program that she was working on, and they have just amazing efficacy for so many things. And I started finally using them after I was comfortable with the data, because when they first came out, I was like, let's wait and see, how
Right.
they go. So probably 2022, I started using them in just a few people that met the right criteria. They were obese, or they had elevated clinically diagnostic obese, or they had type 2 diabetes and their A1C was elevated and things like that. And they have been hugely beneficial for that population. The problem with the GLP-1s, just like peptides, is it has taken off like crazy, and there isn't, in my opinion, very good training around them. The allopathic model is treating them like any other prescription, but there is you need to have certain things looked at. You need to get a baseline body composition. You need to understand you have to get enough protein, or you lose muscle. Patients that are losing weight, 40% of their weight loss is muscle. So you have to address that, and you have to have a clinician that's going to walk you through being on those GLP-1s very safely. I mean, great, you lose 100 pounds, but if 50 of it is muscle, that's not good, right? And so that's a real problem.
So they used to be able to get them from compounding pharmacies at a much more reasonable price. Is that still an option, or did they shut that down?
What they shut down was manufacturing compounding pharmacies, 503B pharmacies, from making them, mass producing them. Where they are still allowed to be made is individual prescriptions by a clinician, by a doctor for that patient. So that's kind of where the gray area is, like, oh, they're not allowed to be compounded. Well, they're not allowed to be compounded by 503B pharmacies at this time. So mass produced pharmacies.
And is there a GLP-1 that you use more often, the one that you prefer?
I typically start with semaglutide and all brand forms of that. We prescribe them from, some patients. Well, they're not as much anymore, but when insurance was covering it, we prescribed a lot of it through regular pharmacies. And when insurance stopped covering it, and it was costing patients $1,400, $1,500, $2,000 in cases to get it, we moved more to compounded, which worked just as well, and in many cases better, because The prescription medications are a pre-titrated dose, and
Mhm.
patients would get very, very sick on that really high dose because it was too much for what they needed. And so the benefit to compounding not only was the price, but also the ability to microdose that and start with smaller doses, especially if your goal was, weight loss. And, I don't have very many people at all that needed 100 units of semaglutide to reach their goals. They could reach their goal as 10, 15, 20 units without the side effects that entails. So that's a good one. And then, of course, tirzepatide. Those are the two main ones on market, branded and compounded. There's a new one coming that's in FDA trials right now, retatrutide, that's a GLP-1, 2, and 3. We're really excited about that one. It's looking like those patients in the clinical trials are having less muscle loss with that one. So we're excited to see that one come out on market and what it does.
Yeah, my son was asking me about that one, and apparently he knows how to get it. Are people getting that off the black market, or is that?
Yeah, the compounding pharmacy we use decided not to utilize that or compound that until it got through clinical trials, and it's just too soon. It's not safe, in my opinion. It's not safe. Now, I have had many of my own patients find it from somewhere and swear by it that it's great, but I'm just like la 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 la.
Well, and then have you seen adverse reactions with the GLP-1s?
Oh yeah. Side effects for sure. And I sadly have had one patient who was unfortunately getting it from a doctor that really didn't understand probably it very well. And this guy had chronic pancreatitis.
Mm.
And he started it, and within about 2 months, he moved into an acute pancreatitis and actually died. Yeah. It was sad. He was only 50. So that was that's part of the danger. You got to understand that these medications are not without side effects. I have several friends still. I come from emergency medicine that still work in emergency medicine. It's some of their number one high admissions to the emergency room is adverse events from GLP-1s, maybe GLP-1s that have been compounded by a pharmacy that who knows where they're getting the API. So I am always leery of GLP-1 medications that you can get out there for $100. Be leery of that, because I know how much these things cost to make, and it's more than $100 if you're getting the appropriate API from a green listed raw materials company. And a lot of compounding pharmacies get them from less expensive sources that aren't tested and aren't FDA inspected facilities. And that's where the danger lies.
Yeah. How do you know that your compounding pharmacy is using the right materials?
I ask questions. And I'm really serious when I say if it's a pharmacy that's selling you that stuff for $150 for a vial, that's a red flag, in my opinion, because again, I know how much these things cost to make, and that's very inexpensive, and that would make me leery of their raw materials.
So the patient goes in, and what exactly should they ask the pharmacist?
Well, their clinician is going to prescribe it to them, and I would ask the clinician, do you know this pharmacy? Do you trust this pharmacy? Have you vetted their compounds? Are they an FDA inspected pharmacy? Do they follow good manufacturing processes? Does their API, their raw material, come from FDA inspected facilities? I mean, there's a lot of good questions people should ask when it comes to injecting sterile compounds into your body. There is a whole process with testing for safety and efficacy that needs to be followed that is very expensive.
Yeah, that's good information. I want to move on to hormones now, because you have an innovative way of delivering hormone replacement therapy, which I'm completely unfamiliar with. So can you tell us what that is and how it's different from what other people do?
Yes, so we primarily use subcutaneous hormone pellet therapy in our patients. I've been doing it for about 16 years. I learned from a doctor that had been doing it for about 25 years. Pellet therapy has been around since the 30s. It was the first researched and studied modality of hormone replacement in women. In the 30s, they were utilizing estrogen pellets in women who had radical hysterectomies. And in the early 40s, research discovers women ovaries actually make testosterone. And so they added testosterone to these women in these studies and saw profound benefits in their moods, their libido, their joint pain, just many other quality of life, all of that. And then Premarin came on market in the mid to late 40s. So by and large, pellet therapy in this country fell by the wayside from being researched and developed because you had this great pill that, magically fixed everything. And they really made a resurgence in this country in the 80s. A lot of European countries started researching. Most of the studies with pellet therapy come out of the 80s and 90s from other countries. And then, of course, over the last 2 decades, they've made a really big resurgence in this country. And I think primarily because of the education around testosterone needs in women. It's a profound hormone that we lose after really that second or third baby. It really precipitously declines, and it impacts so many things that we are treated for allopathically, like depression. My doctoral work was on androgen deficiency and depression in women. So it profoundly impacts mood and depression and anxiety. And of course, libido, energy, muscle. When your testosterone's low, body composition starts changing. And so that's been a really big resurgence over the last couple of decades, is the benefits of testosterone in women. And then, of course, progesterone is a key part of that conversation for women. We don't use pellets for progesterone. It's not really been studied very well. And I've heard they're out there. I prefer to stick to evidence-based medicine on that for sure. So we use oral bioidentical progesterone, which is available commercially. And that's the key thing. We use bioidentical hormones, which a lot of people don't realize. You can get bioidentical estrogen at CVS as a patch, a Bell dot. That's estradiol. So there's many ways you can replace hormones safely and efficaciously, and that's really what I'm focused on.
What do you mean by bioidentical versus non-bioidentical? What does that mean?
It's essentially a molecule that's made from plant sources that is closer. It should be called biosimilar, is really what it should be called. That's really the proper term that we're really trying to move the market to using. So I'll correct myself on that. Biosimilar, but the difference is it's different from a synthetic molecule made from, for instance, Premarin is synthetically derived from the urine of pregnant mares, pregnant mare urine, Premarin. And although it helps beautifully with, with symptoms of hormone imbalance, what we see is it doesn't give all of the benefits of the natural hormone estradiol in the brain and other parts of the body. We do know now, though, based on 2020 JAMA study, that Premarin showed in the Women's Health Initiative trial to be protective against breast cancer and breast cancer mortality. The hormone that was implicated with increased breast cancer in the WHI was progestins, Provera. And so that is, and unfortunately, what happened for women is that arm of the trial that had an increase breast cancer and Alzheimer's disease and strokes, they extrapolated the Provera arm of the trial and applied it to all hormones, and we're still really unraveling from that today. Now, the original authors of the WHI published another paper in 2013 and another paper in 2017, and then their last paper in 2020. And that is where they definitively showed, after looking at 24 years of data, that Premarin, plain synthetic estradiol, which is not estrogen, which is not my first choice, but very protective for women's brains and breast and cardiovascular disease.
Is there anybody that shouldn't be taking hormone replacement? Any women that were?
Yeah, It's not standard of care yet for women that have a history of breast cancer to be on hormone. It's going to be a long time before that flips, although many oncologists and researchers are actually starting to look at that equation a little differently, especially since the 2020 JAMA study came out, and recognizing that, if they have an ER positive or hormone receptor positive breast cancer, that's not a life sentence against hormones. But it's not standard of care. So we don't give women estrogen that are actively going through breast cancer recovery and treatment. It's going to be a while before that changes.
What about fibroids? Do the hormones increase fibroids or change fibroids in any way, uterine fibroids?
Women that have baseline uterine fibroids, which can be caused genetically, there's multiple, they're not really caused by hormones, but what the hormone that can influence them and aggravate them is actually progesterone. So the challenge is in women that are postmenopausal that need estrogen, if they have a uterus, they also have to take progesterone. And that's where it gets kind of sticky, because they need the progesterone to prevent any kind of uterine dysplasia or, any potential for uterine cancer, stimulation of the uterine lining by estrogen. But the progesterone also aggravates the fibroids and they start bleeding, and it's just a whole mess. So that's the challenge with, but it doesn't cause, but it definitely can stimulate those fibroids to bleed. And a lot of young women that have fibroids, and now more and more we're seeing, there's a lot of really great data showing that a lot of these issues like endometriosis, PCOS, and even fibroids have an etiology in the gut, and with hormone metabolism, which happens in the gut. And so that's really fascinating data that's coming out. It's come out in the last, it's about 2023, but really 2025, that we got to kind of pull back and quit blaming hormones for everything. Let's look and see what's happening to that hormone in the body with hormone metabolism and excretion of hormone metabolites that can cause issues.
And so how do you measure that? Is that through your analysis? How do you measure what's going on, how it's metabolized?
The best way that I've found so far that's really very well researched is with urine metabolite testing. We use Dutch testing in our clinics, and it really gives you a great picture. This is for men and women, young girls, young boys, young men. If they have any question mark around their hormones, we want to target first those urine metabolites, because what are you doing with those hormones? And that can give you a really good picture of what pathways you're pushing those hormones down, and what might you be able to do to augment that in a positive way. In other words, some males, especially if they have severe acne as a teen or early hair loss as a teen, I know a young male that has this issue. You would want to look at his urine metabolites to see, is he over pushing his intracellular testosterone down at the DHT pathway, which can cause all those problems. And if so, what can we do to help that? You can take saw palmetto and other things that slow down conversion to DHT. There's things you can do, but urine metabolite testing is a big aspect of that. And then, of course, if a patient has PCOS, endometriosis, other hormone imbalances, GI mapping, gut mapping is vitally important, because that's going to give you a real picture of what's going on in the gut dysbiosis. Do they have too much beta glucuronidase, which causes a lot of issue with estrogen metabolism? And that's a whole another conversation. But I would look at the gut, and I would look at the urine metabolites.
Yeah, the gut is so do you have a favorite test that you use for gut? GI mapping?
GI map.
Just GI map is
GI map.
what you use?
There's several good ones out there. That one just is the most, I've seen the most data around it. I also like it because it tests for SIBO, small intestinal bowel bacterial overgrowth, which is very underdiagnosed in this country, especially with the GLP-1s. Because the GLP-1s slow down motility in the small bowel, and food stays in the small bowel for a long time and bacteria grows. And it's a huge cause of gut issues in patients that are on the GLP-1s. As an example, it also tests for yeast, parasites, fungus, and good bacteria undergrowth and bad bacteria overgrowth. It also tests for H. pylori, which is very underdiagnosed as well, which is a bacteria that grows in the stomach, as you know, for your listeners, that can lead to ulcers. So it's a pretty comprehensive test, and it really gives us a lot of good information.
Great. And I want to go back to the pellets for a minute. So the pellets have estrogen and testosterone in them. Is that right? And then how long does it last?
Yeah, pellets are made testosterone in several different doses for males and females. And then in estradiol, 17 beta estradiol, which is the primary estrogen our body makes and uses. That's what hits the receptors and does all the work. But the clinician that's been trained has the ability to put together the right dose for that patient based on age, weight, blood levels, activity levels. There's many variables that go into choosing the right dose for any particular patient. And then they're placed in the fatty tissue under the skin. And on average for females, they last anywhere from 3 to 5, 6 months, depending on the person, depending on their age, how active they are, et cetera, things like that. You know, if I have a 35-year-old that's got 4 kids and goes to boot camp 4 days a week, she's going to need more fuel than a 65-year-old that's relatively inactive, maybe just walks in the afternoon, right? Same thing with men. They last in men on average anywhere from 4 to 6 months also. I have guys that are big workout. They work out 2 hours a day. You know, they're in the gym a lot. They're going to need more. They're going to burn through them faster. And then I've got, you know, a 90-year-old guy that gets them once a year because they just last so long in him because he's not as active and, you know, he's metabolizing it much slower. So I like the aspect of pellet therapy because you really can dial in on the dose. The problem is there's a lot of clinicians out there that are just ordering pellets from pharmacies and watching a video on how to put them in. And that's the insertion piece is this much of it. You really have to understand what's happening to those hormones in the body, how to dose them, what are the variables, et cetera.
Yeah, and if you don't get the dosage right, you're stuck with it for a bit. Is that right?
For a bit. Nothing, excuse me, my voice is, let me get a drink of water real quick. Nothing really bad will happen except for dealing with nuisance side effects. So in 16 years, and the last count we did, we published some data on hormone pellets. We were looking at breast cancer rates and things. But we had done over 80,000 procedures between my 2 clinics in the last 16 years. And we have never seen one single adverse event. And I distinguish an adverse event from a side effect. Okay. To me, an adverse event is a very heart attack, a stroke, something major, potentially life-threatening. And that's really the FDA guidance definition of adverse event versus a side effect. But side effects are more common in women with androgens because we can be very sensitive. Our hair follicles, where we don't want it, can be very sensitive to the testosterone. And those are managed clinically by changing the dose, lowering the dose, maybe potentially putting them on some certain supplements that can decrease that DHT production, using topical things that can decrease those side effects. But they've never been a deal breaker for patients. They're just something you have to manage, especially in darker hair people like me. They're naturally hairy. It causes hair to grow everywhere where you don't want it. But obviously very, very manageable.
Right. Well, and your practice is in Texas. Where in Texas are you located?
We have a clinic in Southlake, one in Rockwall, and one in Denver, Colorado, actually. And then we train clinicians all over the country. So we have clinicians that come to our trainings every month. We had 700 doctors at our last training. It was amazing. I think more and more clinicians, and I think this is being driven by patients because we train on primarily pellets, but we teach on all the modalities. And people have to understand how to dose shots and creams and orals and commercially prepared and compounded. You got to have multiple tools in your toolbox. But it's a testament, the volume of clinicians that are looking for training in these therapies, because we're realizing as a community, people aren't getting healthier. We spend more on healthcare in this country than any other industrialized nation. We're third from the bottom from health, and that's a real problem. And so I think a lot of clinicians are paying attention to that. Obviously, we know HHS and Secretary Kennedy and the SMAHA movement is really focusing on that, and so forth. So it's becoming very evident that we need to make some changes.
Yeah. Well, thank you so much, Terry. I'll let you go. It sounds like you need my assistance off camera.
I know. You manifested this. I'm like, what can you give me for my scratchy throat? No, I just got good. It's
an easy thing, nebulized saline. When your vocal cords are causing you problems, that's a safe, easy thing to try. But
I will do it today because I've been talking a lot over the last, we just came back from conferences 2 in a row. And so I'm talking a lot. So thank you. I'm going to do it.
Well, it was a pleasure to meet you. This was very informative, and I might come to one of your training sessions at some point.
We'd love to have you.
All right. And everybody, you can buy Terry's book, Hormone Havoc, and go to our website, Exapel. Exapel, sorry. Okay. All right. Thanks, Terry.
Thank you for having me. Have a good day.